Thank you very much for inviting me and for coming. I'd like to share with you some work we've done on child bereavement when a child has lost a parent to sudden death. And so we wanted to talk today about the impact on social, emotional, and physical health, and try to talk some about what are the pathways that may lead to either healthy development or adverse outcomes, and then identify which bereaved youth are at risk for these deleterious outcomes, and then try to identify some things that we can do to help these kids cope successfully with the loss. So about 4% of children will lose at least one parent by age 18. And universally, this is regarded as one of the most stressful life events. And there are a lot of retrospective studies that suggest that there are long-term physical and mental health consequences. One of the things that we'll see is that that different types of adversity are intercorrelated with one another. People don't die young at random, and often kids who lose parents, to premature death, have been exposed to adversity even before the parental death, and consequently would have been at risk regardless. So, but one of the problems is that the retrospective studies don't adjust for that. So you don't really know whether the difficulties that are being reported are actually a consequence of the bereavement or the environment that led to the bereavement. But nevertheless, there's a lot of studies that show, problems with interpersonal relationships, increased risk for depression and poor self-esteem, a number of health effects that have been reported, one of the most famous of these studies is the ACE study, Adverse Child Experience Study, and parental bereavement is one of the 10 adversities that they studied. So the others would be parental criminality, child abuse, I think parental substance abuse, witnessing domestic violence. And basically you get a score of the number of adverse exposures you have. And the importance of this study is that is to show the psychosocial roots of almost every chronic disease. That you have basically a dose-response relationship between exposure to adversity and heart disease, chronic obstructive pulmonary disease, diabetes, cancer, stroke. Some of this is related to lifestyle, but the point is that if you look at the amount of variance that's explained by exposure to these adverse childhood experiences, it's immense. And of course, it's also related to suicide attempt. So it's important to keep this in mind, because what we're going to see is that losing a parent to, sudden death doesn't occur as something in isolation, but that there are often other problems that are associated with it. And so this is a schema that Felitti developed, with the idea that the path from is that these adverse experiences somehow affect social, emotional, and cognitive development, and you are more likely to engage in health risk behaviors and make poor choices. Those risk behaviors then predispose to the diseases that we are talking about, and so consequently, the issues we're talking about have ramifications for health and not just mental health. There really have not been so many studies of parental bereavement that are focused on kids. One study did not find that there was a differential effect of suicide bereavement, which a lot of people believe is different. And in fact, in Searle's study, she actually showed that family function was more disturbed before the parent committed suicide than afterwards. And there actually was a study many years before that by Barraclough that showed the same thing. So suicide bereavement still, it could be different because you may have higher loading for family psychiatric disorder. There could be the issue of stigma. You could have more loading for other types of pre-death adversity, and there's traumatic exposure, either feeling responsible for the death or discovering the parent. All of those things could contribute to people who are suicide bereaved having a different experience. But one of the problems is there are very few prospective controlled studies that have been done in the community. And there are very few that compare different types of sudden death. And the few that have been done didn't really carefully assess parental psychopathology, which you would think would have a profound effect on kids' outcome. And none of them have looked at complicated grief, which we'll talk about. And the few studies that have been done that are prospective end after 2 years. So we don't really know. So you have these retrospective studies that tell you the long-term effects, but there are all those flaws that we've already talked about. And the prospective studies don't go on very long. So therefore, we tried to design a study that addressed at least some of these limitations. And what we wanted to find out is what are the physical and mental health sequelae of parental bereavement, and what pre-morbid and post-death factors might facilitate or impede recovery. And then within the bereaved group, is there a differential effect of suicide? And then try to determine whether there's such a thing as complicated grief in kids. So the probands, meaning that if you're doing a family study, the proband is the person, the index case that you build your sample around. So our probands were individuals, mostly males, who died either of suicide, accident, or sudden natural death. We only took definite verdict of no ambiguous cases. And because we were trying to isolate the impact of the death, we excluded any cases where there were multiple deaths or injuries. And the death had to occur within 24 hours of the initiation of the event. And then we looked at kids who were between the age of 8 and 18, and the person who died had to be their biological parent. And we recruited through the coroners, but we actually then resorted to advertisement, because what happened is a fairly high proportion of the families where one of the parents was bereaved, they were no longer married and had somewhat of an acrimonious relationship, and they wouldn't give us the phone number of the proband's parent or something. So what we ended up doing was advertising, and then a lot of the people who we couldn't get access to responded to us. And we had a relatively good acceptance rate, and that the sample appears to be representative of suicides and accidents in Allegheny County, which is the county that surrounds Pittsburgh, which is where we're from. And ironically, the people that we recruited by advertisement had fewer premorbid risk factors than the ones recruited by the coroner. Usually people that volunteer for things volunteer because they have more problems. So it was a little surprising to us that that's how that worked out. Now the non-bereaved controls, what we did is we got them from a neighborhood that was similar to the neighborhood of the deceased. We used random digit dialing. We eventually gave up on that because this was during the period where people stopped answering their phones. I mean, I did studies years before that where we just would go and knock on people's doors and ask them to participate. I just can't imagine doing that these days, but it worked in that era. And so anyway, these families had to be not have no experience of bereavement. Both parents alive, they didn't have to be married, and they were demographically matched then to the bereaved families. And we assessed the parents and kids for a psychiatric disorder. With regard to the kids, they underwent a TSST, it's a Trier social stress test, to look at their cortisol response to social stress. We ascertained their BMI, blood pressure, and their perceived health. We also got information about their physical health, but even though these kids, the follow-up probably ended, they were in their mid-20s, they really were still pretty healthy as a group. We assessed complicated grief, their social competency, and then the role of the way kids, their coping style, exposure to life events, parental psychopathology and functioning. And then we also looked at the circumstances of death to see if that might be informative about how these kids coped. So we had 99 control families, and we had 60 families where a parent died by sudden natural death, 36 by accident, and 44 suicides. You can see the groups are pretty similar. The sudden natural death were a little bit older, although 47 is still pretty young to die. Mostly male, and the income in those who died of premature death was a little bit lower than the controls, but they were still pretty close. We did our first assessment 9 months after the death, and you'll see that there are these odd times, like 21 months, 33, 62, and 84 months. We were trying to avoid interviewing them close to the anniversary of the death, so that's why we ended up with these weird numbers. We retained 68% over the entire period of time, and the bereaved group was somewhat less likely to have been retained, and but the amount of time that we retained people in the study was similar in the bereaved and the control group. So the adult caregivers were mostly female, and you can see that the proportion who were still married to the proband, before they died, was pretty low compared to the controls. In terms of the kids, they were about mid-adolescent on average, but again, they ranged in age from 8 to 18. And again, a lower proportion of the kids who were bereaved had lived with both parents before the death. The majority of the caretaking parents were the biological mother of the child, but there were some aunts, grandparents that were involved. So one of the first things we learned is that parents don't die young at random. and that there's a sort of mating between parents, so that the co-parent of the bereaved individuals were also at increased risk for psychiatric disorder before the time of the death, and finally that the kids who were bereaved had an increased rate of exposure to adversity and psychiatric disorder before the death. And so this shows you, first of all, the type of things that they were exposed to. So you can see, especially in the suicides, there was a higher rate of bipolar disorder in the probands, higher rates of alcohol abuse, higher rates of depression in the caregiving parents, particularly in the suicides, higher rates of anxiety in the caretaking parents, and higher rates of psychiatric disorder in the kids, antedating the death. And subsequent to, the way that we define something as new onset is that it had to have had its onset after the time of the death. And what we did in the controls is we picked the analogous time that something had an onset in order to call it new onset. So at 9 months, the three types of bereavement look pretty similar to one another, except for PTSD. But what we saw is that there was an increased rate of depression and PTSD in the kids and also in the parents, surviving parents. And when we followed them up at 21 months, we continued to see increased rates of depression, increased rates of substance abuse at 21 months, and also post-traumatic stress disorder. And those differences persisted even when we adjusted for the pre-death risk factors. And if you look at the hazard ratio for the onset of depression, there wasn't a statistically significant difference at this point, but you can see the blue line is suicide, that it looks like it's starting to pull away from the other types of bereavement. And we continue to follow them, and we'll see what happens. But even so, some of that could be from the fact that, as you could see, they had more family loading for psychopathology than the other bereaved groups. And we tried to figure out what some of the pathways to depress, if a kid had a depression sometime between 9 and 21 months, how do they get there? So one pathway was from the parental death, and if you had a depression that was fairly early in the course after the death of the parent, then you were likely to continue to have that. But a lot of the action had to do with the fact that these kids also had a higher rate of depression prior to the time of the parent's death, and that drove a lot of the pathways to depression. So the point is, there was an effect of bereavement, but a bigger effect was the fact that they had depression prior to the death. And we found that the kids who lost a mother were at higher risk than those who lost a father. This has been shown in a number of other studies, although, as you'll see in subsequent follow-up, that finding didn't persist. But we had some subject attrition, so it's possible that that's the reason that it didn't persist. That at 21 months, it looks like that if you had a parent die by suicide, you were at higher risk for depression, prior depression. And if the last conversation with the decedent was within 24 hours, they actually were more likely to be depressed, and if they felt accountable for the death. We then tried to address the question of, is the phenomenology of depression after bereavement different than depression that's not associated with bereavement. And this is before DSM-5 came out. And there, up to that point, there was a big debate about whether you could even give a diagnosis of depression to somebody shortly after being bereaved. It never made much sense to me that you could lose a job, and that's a life event, and you could be given a diagnosis of depression, but you lose a parent or a spouse, you can't be depressed. But nobody said our field is logical all the time. So what we did is we compared the phenomenology of the 42 kids who had bereavement-related depression, meaning started within that 9 months of the death. Then we had 30 kids who were bereaved, who developed depression more than a year after the death. And then some of the controls had depression as well. And, there were some differences, but basically they were similar in severity, in symptom counts, in degree of impairment, and duration, and risk of recurrence. We felt this was supportive of the fact that bereavement-related depression isn't that different than depression in any other ways. There was a couple of things that were different, and I really don't know that they're clinically relevant, but the bereavement-related depression had a lower incidence of the symptom of worthlessness. That's been reported before. I don't really know how to interpret that. I'm not sure that it matters that much, and then the kids who were bereaved and had that early onset depression had their caregiver parent had higher rates of depression and PTSD, which was a consequence of the fact that they were also bereaved. And we then tried to see whether or not there were other sequelae related to health risk behaviors. We did find a higher incidence of substance abuse in the bereaved kids, particularly over the first 3 years. But this was explained by age and whether they had a disruptive disorder and were not functioning as well, and what didn't seem to be a direct effect of the bereavement. And as we followed the kids forward, the rate of substance abuse in the control group caught up to that. I don't know that's a good thing, but that is what happened. Now, complicated grief, it's also referred to as prolonged grief or traumatic grief. It's something that's distinctive from depression or PTSD, although it often co-occurs. And I think the best way you can think about it is it's something where you have difficulty moving on from the death. You're preoccupied about the deceased, you feel bitter, you may feel life has lost its meaning, you might feel numb, you may avoid social situations, and this intense pining or yearning for the deceased. And Nadine Melham, who I've done a lot of work with, she was particularly interested in this. And like a lot of people that are interested in bereavement, she came by it naturally. She's from Lebanon and lived in the south of Lebanon, which was, a war zone for, most of the time that she was growing up. So anyway, she adapted this inventory for complicated grief for kids and was able to demonstrate that in our sample there were about 10% of the bereaved kids that showed sustained, high complicated grief scores for up till 33 months, and at least 40% of them had complicated grief at 9 months. And so she then used latent classification modeling to identify 3 trajectories of grief, which are like high, medium, and low. And the high and medium group, those individuals had a higher risk for depression. So these problems are interrelated, although they still, the phenomenology are distinct. And we found that there was a relationship between complicated grief in the parent and the child, and an interaction. So in other words, the kids with complicated grief, their degree of functional impairment was a result of their own complicated grief, their parents' complicated grief, and the interaction. And one of the things that was quite typical of these kids was that they felt that somebody else was to blame for their parents' death. And Nadine then developed a 6-item screen for complicated grief, and these are the items. You can see that these are the themes that we've been talking about, that not being able to accept the death, missing the person a lot, the shock and disbelief, and then that you have this altered worldview as a consequence. We also looked at other health risk behaviors and found that they had an increased number of health risk behaviors compared to the controls, and particularly the two things were that they were less likely to wear seatbelts and more likely to get into fights. They also had lower expectations about what was going to happen to them. They had lower expectations in terms of the type of work or how much education they were going to have, and it seemed like they had kind of an attenuated view of what the future might hold for them. So I mentioned we looked at the cortisol response to social stress, and if you looked at the bereaved sample as a whole, what it looks like is that they have a higher cortisol at baseline, and and that it's sustained, although you don't really see much of a response. But if you break the groups apart, you can see that the blended response is mostly coming from the kids who were suicide bereaved. And this may be a familial effect. A couple of days ago we spoke about the fact that if you have a family history of suicidal behavior, those suicide attempters having the same test also show a blended response. And they also had a higher systolic blood pressure. Of course, we don't know what their blood pressure was before they were bereaved. And they were more likely to be overweight and obese. We then tried to disentangle, what might be driving this. And we found something kind of curious, which is that that having a parent who was depressed increased your risk for being obese as much as being bereaved. So the two didn't interact, but a control kid whose parent was depressed had about the same risk for obesity as a bereaved kid, regardless of parental depression. So I had mentioned we tried to look at how these kids were functioning socially as they were making their transition into adulthood. So we used something that was developed by Ann Maston called the status questionnaire, and it looks at developmental competence in work and education and friendships, things like that. And we also looked at the quality of their peer relationships and their future expectations. And it turns out that all of these are altered, that they had less satisfying peer relationships, and their career planning and work status and friendships were all less rewarding. Now, we recently took a look at their follow-up at 84 months, which is, I guess, is like about 7 years. And what we found is that there was an increased incidence of depression in the bereaved group, but it only occurred within the first 2 years. And to tell you the truth, most of the action was in the first few months after the bereavement. And we also found that the incidence of depression was mostly in those who lost a parent when they were under the age of 12. There really wasn't an effect of bereavement on depression in the older adolescents. And there have been other studies now that have reported this. And we found an increased incidence of PTSD, but there didn't seem to be a particular time period. In other words, they continued to be at risk for PTSD. And this is consistent with some other studies that suggest that once somebody has had a traumatic experience and develops post-traumatic stress disorder, they have a lower threshold for being traumatized again. So this just shows you the difference in the hazard of depression in the kids, bereaved kids who lost a parent under the age of 12 and over 13. And what you can see is that after the first few months, the incidence of the two groups really is parallel. But it's right after the death that really most of the action is taking place. And in the kids over the age of 13, there's not a statistically significant effect, but it is kind of in the same direction. But they're much closer, as you can see. And we looked at functional impairment, which we use the GAS, which is a scale from 1 to 100, and under 70 means you have significant impairment in at least one domain: school, work, social relationships, and so on. And what we found here is, in contrast to our finding about psychopathology, there was an increase in the risk of functional impairment, but that the two groups continue to diverge over time. I'm going to have to walk you through this slide, but what this is we tried to get an idea of the prevalence of the disorder at a particular snapshot in time. So on the bottom you have basically, between the death in 9 months, and then it's between 9 and 21, 21 and 33, and so on. And it's really just to give you an idea of the pattern. So you can see with regard to depression, the red is bereaved, the blue is non-bereaved, that in the earlier years there was a huge difference between the prevalence of depression in the bereaved and in the controls, but over time they became much closer together. Bipolar, there really weren't that many cases that we could say much about it. But by 7 years, there was more bipolar disorder in the offspring, but that's probably because they had more parents with bipolar disorder. Anxiety, surprisingly, we never found a difference. PTSD, you can see there's a consistent difference in the incident prevalence over time. And in alcohol and substance abuse, as I said early on, there's a big difference between those that are bereaved and non-bereaved, but over time, in fact, by the end, the controls are a little bit ahead. And then with regard to suicidal ideation, you see it's kind of a sustained elevation relative to controls, although this is accounted for by depression. And then functional impairment, you can see that the two groups continue to be quite far apart. So I know it's a busy slide, but it's a way in one slide to kind of get a picture of what has been going on with these folks. So we then tried to see what are the pathways that might have led to functional impairment. The first thing you may notice is that there's no direct path between bereavement and functional impairment, that it's mediated by symptoms of depression and also by the experience of negative life events. And there have been other studies that have shown that kids who are exposed to adversity, whether it's abuse or the loss of a parent, are more vulnerable to experience negative life events, perhaps because their parents aren't monitoring them as closely, and their response to those negative life events is more deleterious. And so this pathway is consistent with that. But in addition, you can see that the history of the fact that these kids had depression prior to had a history of psychiatric disorder prior to the time when their parents died also was contributing to functional impairment, both through the pathway related to negative life events and diminished social support. So to sum up, what we found is that youth who were parentally bereaved were at increased risk for psychopathology even prior to a parental death, but that even adjusting for that differential risk, there was an effective bereavement on depression and PTSD, that the incidence of depression was increased in the first 2 years, primarily in those who lost a parent under the age of 12. I should add that the phenomenology of depression related to bereavement seems similar to depression in general. And that in addition to the issues related to psychopathology, we also saw, kind of a broad matrix of social impairment related to attachment, related to peer relationships, educational and occupational attainment, and continued functional impairment that actually seemed to be the gap between the controls and bereaved kids actually seemed to be increasing over time. Complicated grief was a significant factor in these kids, although in the subsequent follow-up, like at 5 years and 7 years, it was pretty much gone. They had increased health risk behaviors. There was altered stress response and higher rates of obesity and systolic blood pressure. So the risk factors are the usual suspects, parental and personal psychopathology, the ongoing psychiatric disorder, impairment in the caregiving parent, and disorders in the kids. And one of the most powerful predictors of adverse outcomes was that the kid either felt blamed or blamed somebody else for the parental death. And conversely, the things that seemed to protect kids were if the parent was functioning better, if there was a higher family support and cohesion, if the kid's coping style was more adaptive and less avoidant and emotion focused, and if there was resolution of the psychiatric disorder and complicated grief. Now there is one evidence-based intervention for parental bereavement that was developed by Erwin Sandler at Arizona State University. He also developed a parallel type of intervention for families where there's a divorce. But this one is focused on bereavement. It's called the Family Bereavement Program. And it's 12 parallel group sessions, one for the parents, one for the kids, and there are certain times when they bring everybody together. And the parenting sessions focus on improving the parent-child relationship, encouraging the parent to allow the child to express grief, making sure that they continue to monitor the kids and engaged in consistent discipline and supervision. The kids, the focus was on getting them to engage in adaptive coping. And this study had really profound effects. The follow-up 15 years later, they had an alteration in cortisol, which was quite similar to what we found. The ones that weren't in the intervention group had a lower baseline cortisol. The ones that got the intervention had normal cortisol. But there were a good effect. There was positive effects on parental and child mental health, child traumatic grief, and at the 15-year follow-up, there was a lower incidence of suicidal ideation and attempts. So you think about it. It was 12 group sessions, and you're finding effects. 15 years later, they didn't do anything more with these families. So some clinical recommendations that we can make from this. One is that bereaved youth are at risk for psychopathology, and they should be screened for depression, PTSD, and complicated grief, and that most of the action is early in the time after they're bereaved, and that the surviving parents should also be screened. Because if they're not functioning well, the kids are not going to do well. And it seems from our data that if kids did get treatment, and meaning in the kids whose symptoms resolved, they ended up functioning better later. So that suggests that there's a benefit, a long-term benefit to this early detection. And that there are programs that exist, or at least a program that augments family and child resilience that can be quite beneficial to these kids. And that we need to be mindful about the health effects of bereavement as well. And again, it's hard to know. We didn't do as good a job of assessing, like we didn't ever get BMI in the parents, and we certainly didn't know the BMI in the deceased parents. But presumably, you know, there's a reason you die at age 47 of sudden natural death. So some of what we're seeing may not be the effect of bereavement, but coming from a family where the parents weren't that healthy. Anyway, at this point, I'd like to stop and see if you have any questions, and I appreciate your attention. Thank you.